All right, folks, we'll give people a few seconds to move from the waiting room into the main session. See our numbers slowly bumping up there. All right, I think I'll go ahead and start with our housekeeping just so that we give Garbo plenty of time to get through her session. So welcome everyone to session 2 on our last day of the Overdose Awareness series. We're so excited for all of you who have made it through all 4 days. We're seeing a lot of repeat names, which is just fantastic. So thank you all for being with us for this whole month. Today we are going to be talking about treating alcohol and opioid use disorders with naltrexone. So before I introduce our speaker, I'm going to run through some housekeeping. You've heard this every single session. If you need a certificate of attendance, we have a survey for you to fill out at the end of the day today. So once you're done watching our sessions, go ahead and fill that survey out. You do not need to do it for every single session that you attend, just at the end of the day. This webinar is being recorded. It will be posted on our website within the next week or so, as well as Garbo's slides. So please head to our website to check those out. We already have weeks 1 and 2 posted. Hopefully we'll get week 3 up soon as well. I'll have Alex or Justin pop that link into chat on where you can access the recordings and slides. So I will introduce our speaker now. This is Garbo. She is a graduate of the University of Washington School of Pharmacy and is a current pharmacy resident at Kelly Ross Pharmacy Group. Her primary interests include geriatrics and behavioral health. Kelly Ross has been heavily involved in overdose prevention and has provided group education on opioid overdose for outreach groups throughout the community. Additionally, Kelly Ross was the first pharmacy in Washington to provide take-home naloxone kits and continues to be a significant provider of naloxone kits to the community. So welcome, Garbo. Thank you so much for being our speaker today. Folks might also hear from Katie as well, who is also a pharmacist at the Kelly Ross Pharmacy Group. And just a side note, Katie has participated in this series for 4 out of the 5 years. She has been an amazing partner. So we are excited to have her back for 4th year, and hopefully next year we'll have her again for a 5th year. So I will turn it over to you now, Garbo. And please, folks, ask lots of questions, pop them in the Q&A box, introduce yourselves in chat, or provide any other discussion points in chat, but make sure you put those questions in Q&A so that we can be sure that they are addressed. Garbo, take it away.
Awesome. Thanks, Megan. What a nice introduction. I think I wanted to have Katie jump on for a second, just introduce herself and say hello.
Sure, not a problem. As Megan had mentioned, my name is Katie. I'm a pharmacist at Kelly Ross. I precept the residency program. So the folks that Megan had mentioned have participated in the last 4 years. I've just kind of been in the background helping advise and kind of being that person on the chat. So in order for Garbo to give you her full attention in the presentation, I'm going to be kind of working on that chat for everybody. So.
Thanks, Katie. So again, I'm a pharmacist with Kelly Ross. The focus of our presentation today really is on naltrexone, primarily for alcohol use disorder, and we'll also touch on it for opioid use disorder. I do not have any actual or potential conflict of interest relating to medications or treatments that I'll talk about today. I do, though, have an interest in art. All the art that you see, all the paintings you'll see throughout this presentation is from famous painters who have a history of substance use disorder, primarily alcohol use disorder. I want to encourage you, if you have a painter that you love, please feel free to send me an email or a message at the end. My email will be included as part of the final slides. I'd love to learn more about art in the area. So let's set the stage. Questions are invited and encouraged. When you speak up, share commentary on your experience or things that you've learned, or correct me even, we all grow and learn more from this presentation. Second, we also want to have respect for the lived experience related to the content that we'll be talking about today. So just being conscious and sensitive with this material. By the end of this session, we really have 4 goals today. Number 1, we want to describe why naltrexone is hardly ever prescribed, despite its effectiveness for alcohol use disorder. 2, we want to discuss how naltrexone works, how it affects the brain and adjusts brain chemistry, what side effects to expect and how to manage those, and how it's commonly administered. So hint, it's a tablet or injection. We want to compare it to other medications for alcohol use disorder. And we want to also think about naltrexone, how it's used in alcohol use disorder versus how we commonly see it for opioid use disorder. I like starting out understanding a medication from a personal story. Last month, in July of 2024, there was a large article posted in Slate. And the journalist interviewed a woman named Katie Lane. So I'll talk a little bit about Katie Lane's story. In 2017, Katie Lane was blacking out several times each week from drinking alcohol. On weeknights, she would typically down at least 1 bottle of wine, often more. And on weekends, she binged vodka. But even after suffering a clot in her lungs, which her doctor tied to excessive drinking, she struggled to quit. Later that year, a doctor prescribed naltrexone. She noticed immediately, quote, "I would pour a 3rd glass of wine and it would sort of just sit there. I couldn't believe it. It was life-changing." This journalist from Slate kind of dug in, trying to figure out how commonly is this prescribed? What does naltrexone look like when people are trying to get it? And overall, they found approximately 1% of people with alcohol use disorder were prescribed naltrexone in 2023. So the question is, according to experts interviewed, why isn't naltrexone prescribed more? And the reason is complex, and it boils down to 2 factors. One is stigma around alcohol use disorders. This means that alcohol use disorder is often seen as a lack of willpower rather than a medical condition or a disease. And that's true from people within the medical community holding that point of view. And 2 is lack of knowledge around naltrexone. What is this medication? How do I even prescribe it? So in order to understand that first problem, stigma around alcohol use disorder, we're going to start with a myth. In the chat, can you tell me true or false? Using alcohol or other drugs is a choice. So if someone gets addicted, it's their fault. So go ahead and put in the chat true or false. It's kind of a controversial thing to start out with. So go ahead, welcome to put either way. We're going to discuss it together. This is a safe space. Okay, thank you everyone for your participation. It warms my heart to see so many replies in the chat. So false. If someone were to pick their own life path, I don't think most people would hope for harm for themselves in the future. I don't think most people would choose to become addicted any more than they choose any other medical problem. What we now know is that addiction is a consequence of many contributing factors, including genetics, upbringing, trauma, and other influences. In a recent study, science estimate that genes, including the environmental factors that have an effect on the person's expression of genes, account for 40 to 60% of a person's risk for addiction. So we have clear evidence that this is a complex disorder influenced by their genes, their environment, and their past life experiences. So from the beginning, substance use disorders are not a choice or a bad habit or a personal moral failing. It's not someone not caring or being unmotivated to change. Let's define addiction. So addiction, according to the American Society of Addiction Medicine, is a chronic brain disease. So chronic on this slide, meaning happening throughout their life. Relapsing, meaning coming up again, has the potential to come up and up again, like waves in someone's life. And then disease of the brain, meaning the substance in their system changes their chemical circuits of their brain. It's characterized by compulsive use despite harmful consequences. This is how we typically diagnose a substance use disorder. So compulsive use, meaning someone has the inability to stop. And second criteria, typically harmful consequences, meaning that they have something negative happening in their life, affecting their job, their health, their families. But despite that, they're unable to stop use. Okay, myth number 2, people with substance use disorders do not want help or medical care. True or false? Put it in the chat. Okay. So I'm seeing a gathering of responses around false, and I would agree with you. So interesting, Washington State Syringe Exchange health survey in 2017 asked this question: why aren't people getting medical care? And they found that it was not wait times. I just see Aaron put in the chat stigma, and I want to emphasize that. There was a time, they said, when they should have gone for care, but did not, largely due to perceptions of how poorly they would be treated or judged by healthcare providers. And as a result, many may delay care until problems become more acute or costly to treat, or just avoided getting care altogether. More respondents reported getting medical care at an emergency level or an urgent care level in the last 12 months versus in clinic. My conclusion from that is that it really matters the language that we use, and it really matters how people feel they're being treated. My second conclusion, and this is just my own commentary from the study, is that many who filled out this survey were interested in medications for their substance use. Actually, 69% of respondents said that 69% of respondents with opioid use disorder said that they were interested in medications to help decrease use. So my second conclusion from this study is that medications are something that people are interested in when they're looking for help. Let's talk about fighting stigma. So first, we need to understand substance use disorders, including alcohol use and opioid use disorder, as chronic, treatable medical conditions. Number 2, and this is from addiction medicine expert that I spoke to, is that it is our job to demonstrate that we know they are a complete person. It is our job to help recognize their good qualities. They already know they're negative. Patients are often defensive and feel like others are judging them negatively. This is both because they are often judged by others because that's their norm, that's their life, and because they are often judging themselves negatively due to internalized guilt or shame. It is our job to go out of our way to show we are not judging them for their addiction, and recognizing the good in people can be profound. So we can say things like, you are an intelligent and caring mother, and you're someone who lives with addiction. Or you are an incredibly talented painter, and you're someone who struggles with alcohol use disorder. Addiction is part of who they are, but not all of who they are. So now that we've addressed that first point about why medications for alcohol use disorder, including naltrexone, are not prescribed, mainly due to stigma, let's address the second point. What does lack of knowledge around naltrexone look like? So in a 2022 survey, they asked 150 doctors across 3 Mayo clinics, a very prestigious center in the US, in 3 different states, Arizona, Minnesota, and Florida. And most doctors reported that they just simply hadn't heard of naltrexone, and they didn't know enough to prescribe it. Doctors who didn't prescribe the drug were more likely also to report wrong information about it. Katie, who we talked about earlier in this story, Katie Lane from the Slate magazine article, she had to go to 5 doctors before she found someone to prescribe naltrexone, and many of them pushed her off, said she had to go to inpatient rehab first, or she had to be abstinent first. which is incorrect, before they said they would prescribe naltrexone. So let's reframe alcohol use disorder and medication use in alcohol use disorder. Medication instead can be viewed as a tool on the tool belt. So it's one thing that we pull out to help someone. But according to the American Psychiatry Association guidelines, it's not the only tool, right? We have behavioral interventions. This could be counseling. This could be cognitive behavioral therapy. This could be something called motivational enhancement therapy. This is not my area as a pharmacist, but something that I hope I could help refer someone for care. This includes social support like peer support groups or 12-step facilitation. This could be lifestyle changes. And then there's other things that I just have trouble putting my finger on, but are important to recovery. And that's hope, that's life stability, that's purpose and belonging. And all these things come together to help support someone. I found a 2020 study that looked at treatment success and recovery from alcohol use disorder. And they actually found that combination of behavioral interventions like CBT and medication set the person best up for success. And who are we affecting when we say substance use disorder? A large 2023 survey looked at how many people in the US are affected by substance use disorders. And 17.1%, or almost 50 million people are. This is about 1 in 6. When we talk about alcohol use disorder today, we're talking about roughly 10% of the population meeting that criteria. So from here, I'm going to talk a little bit about naltrexone for alcohol use disorder. Just a reminder that I'm a pharmacist and I'm not going to go over how to diagnose it. I'll just focus on medications. But since we're at a nice point here, I'm going to turn to Katie and Megan and just see if there are any questions that I need to address at this time.
Nope, no questions have come through yet.
Perfect. Thanks so much. So whenever someone comes to you with alcohol use disorder, your mind needs really to separate into 2 buckets. The first bucket goes first, and is this person in acute withdrawal? Do they need medications to help them safely move through withdrawal? So this is a question I ask. Does the person need help with their withdrawal symptoms? Under this bucket, we say to ourselves, do they have a need for medical assisted withdrawal management or detox? I understand as part of the overdose awareness series, there's a whole session on withdrawal and managing withdrawal, so I'll refer to that. And then when we think about medically assisted withdrawal, is it severe enough that someone needs to be treated in the hospital, or can they be treated outpatient, or can they be treated in their home? Know that medical withdrawal helps stabilize the person, but is not ultimately treating the underlying alcohol use. And this is not what we're focusing on today. Naltrexone or other medications discussed today do not address withdrawal. This is a separate bucket. The second bucket, which is where we'll live today, is do they need medications, or do they even want medications to help with their alcohol use disorder? These are the 5 medications that we often see. The ones with the black stars, naltrexone, camprosate, disulfiram, have FDA approvals for treating alcohol use disorder. Other 2, gabapentin and topiramate, I see as well. Those don't carry the FDA approval, and they often have less evidence, so we'll spend less time talking about them. And just a reminder that sobriety is not, or abstinence is not the path for everyone. Among addiction medicine experts, any reduction in drinking is seen as a win. So we want to think about medications not only to help someone with one particular goal. We want to talk to them about, is your goal to reduce drinking, binge drinking days, to help with cravings? How are we matching medications to help with that? Okay, myths are getting much harder, so feel free to take a guess on this one. Myth number 3, true or false? People need to stop drinking to use medications for alcohol use. And take a drink of water. True or false? Okay. So thank you for your responses in the chat. False would be the answer. And let's kind of dig into this so we can all get on the same page. So again, these were all the medications we talked about and can be used with alcohol use disorder. The ones with the black check marks can actually be used and the individual can continue drinking, right? These medications, while they continue drinking, can help them reduce number of drinks per day that they're drinking, number of days per month that they're drinking. So it's really it could be a benefit depending on the individual's goals. The only one that cannot be used while the person continues to drink alcohol is a medication called disulfiram. Disulfiram causes a violent vomiting-like reaction when the person takes it with alcohol. So we'll talk a little bit more later about why someone might choose disulfiram to enforce abstinence on themselves. Okay, but that would be the only one where they cannot continue to drink alcohol and use these other medications. So I want to give you a heads up. Here comes an analogy. We're going to talk a bit about how alcohol works in the brain so we can understand how naltrexone works. And hopefully with this analogy, it'll help you remember why this medication is so unique. Okay, so picture a room and you have these chairs in it. These chairs are going to represent our opioid receptors in our brain. Okay. When alcohol sits on one of these opioid receptors, it's going to stimulate it and your brain's going to release chemicals. The chemicals that it's going to release are endorphins, right? Like our happy, natural occurring opioids. They're going to release into our brain and make us feel happy. This will also trigger a dopamine release or dopamine rush, which then feels good, pleasurable, and rewarding. So when someone drinks alcohol, they release endorphins, feel good, dopamine rush, alcohol then feels pleasurable and rewarding. So how does naltrexone interrupt this process? Okay, so instead of alcohol sitting in the chair, let's picture naltrexone sitting in the chair. Naltrexone to me in a room is like my Uncle Jimmy coming into the room. Uncle Jimmy comes into parties, he sits in the chair, he does not get up. He goes, "This is my chair. I'm here for the rest of the party. If you want to come talk, you talk to me, and I'm just going to block it." And he doesn't just block one, he blocks all the chairs at the party. Okay? So he sits there. If alcohol comes along and goes like, "Oh, I was actually going to sit there," he's going to be like, "Sorry, too late. You have no effect. You don't cause an endorphin rush. You don't cause dopamine release." The goal there then is that alcohol is pulled apart from that pleasure and reward feeling. It's no longer has that pleasurable effect. And the goal then is that it's reducing cravings. Quote from one patient is that they started taking it and they just had no desire to drink. And all of a sudden, alcohol tastes like rubbish. And I want to reiterate that this is like, you have a study, not everyone responds this way. Some people feel this way, some people don't. But this is how we understand naltrexone to work in the brain. So what does that look like when it comes to outcomes? In these big studies, we ask patients, okay, you weren't on naltrexone, now you take it. How do you feel? Some patients say that they have reduced cravings. When we tracked number of days that they drink, we saw decreased heavy drinking days or binge drinking days. We saw decreased drinking days overall, and then decreased likelihood to return to drinking. I'm going to stay on this just for a second. So even if a person relapses, naltrexone will prevent them from really achieving that same relaxed, good state they were used to with prior alcohol consumption. So over time, the brain begins to pull apart alcohol and that happiness feeling, which helps people stay either in recovery and abstinent or just using it less. Moreover, there was one study where people, when they were in the hospital for alcohol withdrawal, were given naltrexone when they were exiting, and they saw 42% fewer returns to the hospital and deaths within 30 days. So this is really a medication that can benefit people with alcohol use disorder. How do I take it? It's available as one tablet that you take once daily, or an injection that you get once per month or every 4 weeks that's administered by medical personnel at a clinic. If I were taking this medication, I'd want to know about side effects. In the category of medications, we usually call this well tolerated. Well tolerated is coded for just like not much to write home about. I don't really feel any side effects of this medication. About 10% of people will feel these two things that I'll describe. So you want to take the medication with food because it can cause stomach upset, nausea, and vomiting. This usually happens the first few days, the first few weeks, and then resolves. We also tell patients often to take it at night because it can cause difficulty sleeping. From talking to people, difficulty sleeping can be like insomnia, agitation, vivid dreams. It can also be the other end, which is like sleepiness, fatigue, like tiredness. Could be either. And again, goes away after a few days, few weeks. For rare side effects, rare meaning less than 1%, they saw liver damage or depressed mood. More research is showing that these liver changes are really unlikely to happen, but rather continuing to drink or drink a lot is a bigger risk to the liver than the small liver changes they saw while patients took naltrexone. Depressed mood as well. They saw some people who weren't taking naltrexone also felt depressed, and some people who took naltrexone were depressed in the studies. So it's a little bit unclear if this is something that we should be really worried about. But because we're pharmacists, we want to make sure that people are aware of all risks. We would talk to them about liver changes and potentially depressed mood. I think cost is really important. The oral medication or the tablet is cheap and often covered by insurance. And the injection, called Vivitrol, that's the brand name, may require additional paperwork to approve through insurance. The injection as well causes soreness or redness at the injection site. And just a reminder that this person would need to be able to come into clinic every 4 weeks to get that injection by a medical provider. This is not something they'd be able to self-administer at home. Okay, so we're going to return to how naltrexone works in the brain and come back to the same analogy to understand how opioids in the system might affect a person. Okay, so I'm going to just recap the same thing we said before. You have these open opioid chairs in the brain. Picture them like chairs in a room at like a family gathering. That's my analogy. Alcohol comes to the gathering, sits in that chair, stimulates the opioid receptor to release endorphins. Feels good, you get that happiness feeling and that dopamine rush. Again, naltrexone comes to the party. Uncle Jimmy's there. He's like, ooh, my favorite chair. This is mine. So happy I got here early. Best spot. He blocks any effect of that signal being sent. There's no endorphins. There's no that dopamine rush when alcohol and opioids show up. So again, he's sitting in the chair. Alcohol and opioids come to the party, and he goes, "You snooze, you lose. Too bad I'm already here." And he blocks their effect, uncoupling or pulling apart alcohol and opioids effect from that happiness and dopamine rush. And again, just so that we're all on the same page, opioids are heroin, oxycodone, buprenorphine, methadone, hydrocodone, or fentanyl. Other meds too, but just a short list here. So in this last example, this is what would happen if naltrexone was already in your system and alcohol and opioids show up. Second example, what happens if opioids are already there? So if opioids are already in your system, opioids are going to sit nicely in that opioid chair. in the room. And they're going to do well at stimulating your opioid receptor to release your endorphins and cause that happy, relaxed state. And unlike alcohol, opioids really sit hard in that chair. They sit in the chair much longer in our brain, maybe even up to 48 hours, and hold on very tightly. Fortunately, Uncle Jimmy is quite stubborn. So if he comes to the party, he's going to kick him out of the chairs. He says, I don't care if you're here early. This is my chair. I love it. You think I have seniority here. I've been around longer. You don't even know opioids. And he kicks them out. What this would then cause is a sudden loss of opioid effect. And that's the withdrawal people feel. And that's really the concern that we have, is if opioids are already in the system and Uncle Jimmy shows up, they're gone. And then the person's in withdrawal. So let's recap so we're all on the same page, because we're talking about medications in the brain and we want to make sure we understand it. So point number one, if you take opioids and naltrexone's already in your system, opioids won't work well, right? The chair is occupied. They can't have their effect. If you take naltrexone, when you've been using opioids for a while, withdrawal is going to happen. Uncle Jimmy's going to come in there and kick opioids out. They are gone. So then what we need to explain to people considering naltrexone is that they must be abstinent from opioids for 7 to 14 days prior to starting naltrexone. And the safest thing to do then is just be forthright with what you're taking. And this is so that we avoid sudden withdrawal from opioids. And if you've had opioids in the last 7 to 14 days, let's find another medication. If you're taking opioids for chronic pain, naltrexone is not the right medication for you. If you want to continue using opioids or keeping them in your life, naltrexone is not the right medication for you. And that's okay. There's other options out there. So that's really the summary around naltrexone and opioids in the brain. Did any questions come up in the chat about that?
There is one question. So, any evidence at all that naltrexone helps with opioid cravings?
Yes. Yep. Great. Whoever asked that question, good intuition. So similar to alcohol, naltrexone also helps with opioid cravings. Because it's blocking that effect in the brain and pulling apart opioid from its effect of relaxed happiness state. If opioids no longer cause that for you, why would we? Maybe we just don't want to use it. Okay, thanks, Megan. We're going to do a side-by-side, last few slides on alcohol use, and then we'll touch on opioid use. So naltrexone is the one we've been focused on. It's available as a tablet once daily or injection monthly. Acamprosate, other medication we'll talk about, is a tablet where you have to take 2 tablets 3 times per day. It's quite a bit more. And that's the main complaint about this medication. A little bit hard for people to remember to take it so often. Disulfiram, 1 tablet a day. Next question, can I continue to drink? Remember that myth we went over and thinking about the check marks. Naltrexone and acamprosate, totally fine to continue to drink. Even might have some evidence to help reduce your drinks. So it would be great to have it on board. Disulfiram, no. It discourages drinking by making the person physically ill when alcohol is consumed. So it is not the right choice for someone who wants to reduce drinking. For common side effects, we have talked about kind of the stomach issues and sleeping issues when people start naltrexone. Acamprosate, you'd probably have a pretty similar conversation, except only on stomach issues. You would say, yeah, it upsets your stomach a little bit when you start the medication, but it usually goes away, and I'd recommend taking it with food. That's for acamprosate. Disulfiram, totally fine, except if you take alcohol. If taken with alcohol, expect violent vomiting, fast heartbeat, sweating, and other effects. For rare side effects, right, we're talking about liver damage with naltrexone, kidney damage with acamprosate, or liver damage with disulfiram. Again, these are small changes that happen less than 1%, less than 0.5% of people studied. And additionally, we know that alcohol is much worse for your liver and kidneys. Can I continue to use opioids? No, with naltrexone. And again, it would get kicked out and induce withdrawal in that person. For acamprosate and disulfiram, no issues. It does not work in the brain that way. So therefore, they could continue to use opioids. Lastly, would comments. So we've talked quite a bit about naltrexone, so there's not really much to add there. But acamprosate, the one thing people comment on is just the number of tablets to take daily. 2 tablets 3 times a day daily is just a lot to take and remember. For disulfiram, you really have the consequences of drinking in combination with disulfiram, and there's often we see better evidence for the use of naltrexone and acamprosate. Therefore, disulfiram is generally not chosen as the first option for most people. It would be best for people who are seeking abstinence and those who understand the negative reaction that would happen if they were to drink. So our first choice options, therefore, are naltrexone and acamprosate, and then disulfiram if that's really what someone wants and needs and understands to help them with their sobriety. There are 2 other options we mentioned in these slides. That's gabapentin and topiramate. These are not FDA approved for alcohol use disorder. There's less evidence to support their use, but people are using them with good effect. They're not often used, but I see them at the pharmacy. Just because they're not as high up doesn't mean that they can't help some people. I'm including more information as part of our extra slides at our end. Send Megan or Katie a request that you'd like me to go over them, and we'll cover them at the end, but just going to leave those aside just because the 3 main ones, naltrexone, acamprosate, and disulfiram, are the ones that you'll see most often. Who is a good candidate for naltrexone for alcohol use disorder? I would say, based on the information we talked about today, it's clear that it's really most patients. It's those who want 1 tablet daily or an injection monthly, those who are trying to cut back on alcohol use, or those who are trying to be abstinent. And then lastly, like also making sure the person wants to start a medication for alcohol use disorder. Who is not a good candidate would be someone who uses opioids chronically, or those with severe liver disease, meaning end-stage liver disease. So we're at our last myth, and probably the most difficult one. So appreciate any participation in chat on this one. If you're going to use medicine for alcohol use disorder, you must only pick one, true or false. Welcome to take a guess. Yeah, I love to see guesses. Thank you for your participation, everyone. Great. So I see some true or falses. Thank you so much for chiming in. So actually, false. Studies have shown that it's safe to combine these medications to treat alcohol use disorder. I found 2 studies that I'll highlight. So one that used naltrexone and gabapentin, where they found better results using both. Another with naltrexone and acamprosate. And just out in the field, I've seen a number of combinations of medications that people are taking. Remember, we're not throwing medications at a problem. We're talking to someone about their treatment goals. And ultimately, what their goals are should dictate what we prescribe or not prescribe. Second, we know the data supports a whole tool belt of tools, not just one single hammer. So combination of non-medication and medication treatment is really what we should rely on. And then all the other things in their life, like stability, hope, belonging, peer support, all these things that make a person whole. So think about all the ways to help the patient, not just could another medication help. And I'd encourage you to talk to your doctor or refer a friend to talk to the doctor about options. So from here, we'll transition to opioid use for a few slides, and then we'll talk about resources. Any questions before I transition to opioid use disorder, Katie or Megan?
I'd say go ahead and move forward, and we can save the rest of the questions for the end.
Great. So I'll read out the statement on the bottom of the slide. So since the focus of this presentation is mainly naltrexone for alcohol use disorder, we will briefly go over naltrexone for opioid use so you can compare and contrast the difference. Opioid use disorder medications are available, ones that you've probably learned about in your line of work or through friends, or even maybe over the course of these overdose series is methadone, buprenorphine, and naltrexone. And as I've emphasized, there's no one size fits all approach. We're thinking about what does the individual want and need when picking one of these medications. On this slide, I'm highlighting naltrexone in alcohol use disorder in brown and naltrexone in opioid use disorder in blue. So when we look at alcohol use disorder, we see that naltrexone is available as an injection or a tablet. Where in opioid use disorder, they found better data with just using the injection, not so much the tablet. And that's because people had more difficulty remembering to take it daily. How does it help? For alcohol use disorder, it helps with reducing cravings. We also talked about days drinking, binge drinking, returning to use. With opioid use disorder, we know that it helps in the brain as well with reducing cravings. How effective is it? We actually have some pretty good data to support its use, and that's why the American Psychiatric Association puts it as a first line or top option. For opioid use disorder, it's just not as effective as other options. The data is not there to support its use as much in opioid use disorder. Is it a first-line medication? Yes, meaning in treatment guidelines, they usually pick out a acamprosate or naltrexone as first line or the first thing you would reach for when someone is saying, I'd like to consider medications to help me with my alcohol use. With opioid use disorder, it's more fuzzy gray answer. No, for most patients, you're probably going to prefer buprenorphine or methadone if you can get someone set up with a clinic. It's kind of, as you can tell, a different story between these two use disorders. And then, does it require abstinence? With alcohol use disorder, an individual can continue to drink, as we talked about, and use naltrexone. They cannot continue to use opioids, though, with naltrexone if they have opioid use disorder. So then, who would be a good candidate for naltrexone for opioid use disorder? In the guidelines, they highlight those who do not wish to take opioid agonists, that's our buprenorphine and methadone, those who've been abstinent for 7 to 14 days, right? As we covered, that's because they're at risk of withdrawal if we have the two overlap. 3, they don't have the ability, they cannot go daily. It just doesn't work in their life to go daily or almost daily to an opioid treatment program. And then lastly, they highlight that often those who find success with naltrexone for opioid use disorder are part of a program with monitoring. And that monitoring results in immediate consequences if they're not compliant or adherent with that program. So now some resources. How can I find someone to prescribe naltrexone or other medications? Really, any provider can prescribe naltrexone as long as they're knowledgeable, which hopefully we can help increase more providers' knowledge about this medication and they're comfortable. So I would recommend talking to your doctor, talking to a counselor, therapist, peer support specialist, try and see if they know someone who knows someone or get a referral. Social workers can be a great place to hook up to resources and then talk to others in your community as well. These are specific resources on ways to look up providers, but again, really anyone can prescribe it, so you don't need to go through any special program. So Vivitrol, that was the brand name of the naltrexone injection. On their website, they actually have a provider lookup resource. So you can put in your city, state, or zip code and see if there's a provider in your area who can administer or prescribe the medication. Our big substance abuse and mental health organization nationally has a buprenorphine practitioner locator and an opioid treatment program directory. And you can use these links to look up whether you can find someone in your area. Let's recap what we learned today. So naltrexone blocks the pleasure and rewarding feelings associated with alcohol and opioids and helps with cravings. 2, naltrexone is a preferred medication for alcohol use disorder. 3, for most people, side effects from naltrexone, including stomach issues and sleep problems, can be managed and are often short-lived. People can continue to drink or not drink while taking naltrexone. People must be abstinent from opioids while taking naltrexone. And naltrexone, while it works for some people, is not a preferred medication often for opioid use disorder. That's it. Again, my name is Garbo. I'm a pharmacist with Kelly Ross. Thank you so much to the Poison Control Center for having us today. I'm including my email here with encouragement to please send me recommendations for art, corrections to what I said, questions. I'd be happy to talk to you. And last little push for, there's a local doctor who makes art who then she sells the proceeds from these sales for these products, including one that has a narwhal on it saying naltrexone is harm reduction. All the proceeds from these sales go to buying supplies for harm reduction practices. So if you're interested in art and art around this topic, this would be a great place to go. Thank you so much.
Thank you so much, Garbo. I think all of us probably have an Uncle Jimmy in our lives that takes up the chairs at all those parties. So that was a great analogy. Thank you.
Yeah.
All right, folks. So please start putting in your questions into the Q&A box. I saw that Katie's been answering quite a few as Garbo's been speaking, but how about we just go through those to make sure that people didn't miss them, as well as to see if Garbo has anything else to add.
Sure.
So the first question is, has naltrexone been studied with nicotine dependence?
Katie, did you answer that?
I did. So there have been, a couple studies here and there, and I am by no means an expert on them that have looked into naltrexone use during smoking cessation. And what I've really noticed, generally speaking, is it's looking mostly into weight gain that's associated with getting off of nicotine, and it's in combination with another medicine called bupropion. Um, it's certainly not an approved indication for it. There are other medicines like Chantix and bupropion SR that are approved for nicotine dependence, specifically just like there's other medicines for opioid dependence that are different from alcohol. That being said, there's a lot of uses for naltrexone that are off-label. So, 5 years from now, I don't know what differences I'll be saying, but as of now, that's generally what I'm aware of. So.
Perfect. Thank you. Okay, I'm seeing a couple new questions come through. So this one's from Brittany. Are there any concerns to starting someone on naltrexone in the ED for alcohol use disorder, similar to how we are seeing patients with opioid use disorder be able to start medications for opioid use disorder like buprenorphine prior to discharge?
I can take that question. So yes, there are concerns, right? When someone is in the ED with alcohol use disorder, remember we need to sort them in really to two buckets, and that first bucket has to go first. So are they in alcohol withdrawal, and do they need help with alcohol withdrawal symptoms? In that time frame, this is not the time to think about naltrexone or other medications that helps reduce use. That's the time to stabilize a patient so they don't have harmful effects to their body from withdrawal. After that period, we can then move. Usually it's if they, after that period, maybe like 5 days a week, then we can start talking about medications to help with relapse or reducing use.
So I have a follow-up question with that. Can you speak a little bit more to the relationship of withdrawal with naltrexone, since we learned in a previous session that withdrawal from alcohol can be fatal. And so if someone is using naltrexone to decrease their use and they're experiencing any sort of withdrawal symptoms, how else are they helped through that? Do they need to not use naltrexone while they're going through withdrawal? Just
Yeah.
curious about that relationship.
So anytime, great question. Anytime anyone's going through withdrawal, we need to make sure that we're assessing the severity of withdrawal so we understand whether they need to reach a level of inpatient in the hospital, outpatient, or in their home. And pretty much based on those levels, we'll figure out whether someone is safe to continue on naltrexone. And sometimes if it's not severe and it's short enough, we're just not as concerned about someone stopping or starting naltrexone. But honestly, like withdrawal is just totally a separate bucket and separate beast. So if someone's in withdrawal, we should really focus on supporting them through this time. And if we have to stop naltrexone, it's okay. We can just restart it in a few days. Okay.
Anything to add, Katie? Great. All right, next question. Naltrexone and bupropion for methamphetamine addiction. Any comments?
Not No, not off the top. I've read a little bit about bupropion for methamphetamine addiction, but I'm not the best person to speak to that today. Um, I would have to look into it and get back to you with a better answer. But if you wanted to send me a direct message or a group a direct message with your email, I'd be happy to follow up.
Sounds good. All right, let's go back to some of these previous questions. We had one, well, we had one about what happens if someone drinks on disulfiram, which I think you addressed that. So another question from Angela, can naltrexone decrease dopamine rush or endorphins in general? Katie responded saying it specifically works to reduce dopamine release by blocking the opioid receptors. That being said, there are a lot of off-label uses for naltrexone, including low-dose naltrexone, and not always is the mechanism well understood. Do you have anything you want to add to that, Garbo?
No, I feel like that's a good answer. Thanks, Katie.
I have a question for one of my Poison Center colleagues on what are some of the other off-label uses?
Of naltrexone. Katie, do you want to jump in on that?
Yeah, so all the off-label uses are what they say is off-label. And I'm not going to pretend to be an expert on all of them, but pain, inflammation. I think I've heard of depression as well for that, but none of which I can speak to the point that I would recommend for those out of the box. So.
Hey, I'm not seeing any other questions come through. So I'll ask you our final question that we have been asking all of our presenters. What is one action step that you want our attendees today to take based off of your session?
As a person, um, I would say appreciate people for all of who they are. Don't let one action define how you understand them. As a medical practitioner, talk to if you need help, talk to your doctors, talk to your providers, talk to your pharmacist about options. They're always happy to run through what different paths look like. including medication-assisted paths.
It's a perfect answer to end this session today. Thank you so much, Garbo, and thank you, Katie, for offering support and some additional answers as well. I know I definitely learned a lot today. I've really only considered naltrexone with opioid use disorder, so this was very interesting to dive into alcohol use disorder. Everyone, please be sure to fill out that survey by the end of the day. If you're attending any of the rest of our sessions, just wait until the end to do that. Our lunchtime session, as Alex mentioned earlier this morning, is a bit different. It's an Ask Us Anything style session. So we'll have one of our medical toxicologists on, as well as our managing director of our call center and us educators. So you can feel free to ask us any of those lingering questions that have come out throughout the series this month. So we will see you at 11:45. Thank you again so much for your time and expertise, and we hope to see Kelly Ross back with us next year.
Thank you so much.
Bye, everyone.